join us today. So welcome to the latest of Parkland Institute's webinars as we kind of talk about the launch of our latest report, Operation Profit. We're looking forward to that chat today. Before we get going, I just want to acknowledge that those of us who are in Alberta anyway are on Treaty 6, 7, and 8 territory. I'm in Treaty 6 territory, which is the traditional home and gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Papachase, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others. I think it's important that as we go about the work that the Parkland Institute attempts to do, which is to kind of share wisdom, learn from one another today, and as we try together and collectively to try and examine how we can build an equitable and resilient communities in the face of growing racism, hate, and violence that we have been seeing in recent years. I think it's critical that we do so with an eye to the land and its people, and in the spirit of reconciliation and decolonization. And I think particularly when we talk about healthcare, which is what we're talking about today, I think thinking about how we care for one another is something that we can carry with and through us as we talk over the next hour and as we continue to do our work around trying to do a better job of caring for one another. So today, with this webinar, hoping that we'll have a lovely, interesting and useful and important chat and conversation about private surgical contracts and what happens when governments contract out something as key as surgical services. Nothing can be more crucial in this point is in terms of our healthcare, and I think reckless experiments with how we deliver that healthcare can have great consequences for all of us. And so I think it's really, really important for us to have this conversation. Before I introduce our speaker, let me just kind of walk through how the day is going to play out for a little bit, or the afternoon is our presenter will present for about 20 minutes or so, which hopefully leaves us about 25 minutes, half an hour for questions and discussion. I'll explain how to do the questions at the end of the presentation. And then I do give you a commitment that we will get you out of here by 1 o'clock Alberta time. That's the time we promised. And so I'm going to try and stick to that. So let me, without further ado, introduce our speaker for the webinar and the author of our latest report, Andrew Longhurst. He's a political economist and health policy researcher and PhD candidate in the Department of Geography at Simon Fraser University. His research has been published in academic journals and by research institutes, including the Canadian Journal on Aging, Political Geography, the Canadian Centre for Policy Alternatives, and the Parkland Institute. His recent publications include At What Cost? Ontario Hospital Privatization and the Threat to Public Health Care, which he did for the Canadian Centre for Policy Alternatives in Ontario, and Failing to Deliver, the Alberta Surgical Initiative and Declining Surgical Capacity, which he did for the Parkland Institute. So you can see we have a theme running in some of his recent work. And he is also a research associate with the BC Policy Solutions. So without further ado, I will hand things over to Andrew to walk us through his latest report, talk about what it might mean for us as Albertans and Canadians. And go ahead, Andrew.
Thanks so much, Jason, and thanks for everyone for being on this webinar for your noon hour. I'm going to share my screen and we'll get underway. All right, so just to start us off, as many of you know, we have a backdrop of ongoing allegations of contract irregularities and price gouging that may involve Alberta cabinet ministers, political staff, and the for-profit surgical industry. And this report highlights a surge in the average cost of outsourced procedures, a steep increase not justified by inflation or service complexity. At the same time, a troubling trend emerges as Alberta's real per capita hospital spending declines while funding for for-profit surgical facilities grows significantly. And after 5 years, the Alberta Surgical Initiative is still failing to deliver increased provincial surgical capacity and reducing wait times for most priority procedures, despite claims from government otherwise. So as many of you will know, and I won't spend too much time on the relevant background, of this issue. It's been widely covered in the news media. But Athana Metsalopoulos, who was removed as Alberta Health Services CEO in January 2025, has come forward with allegations of political interference in surgical contract negotiations, claiming that the government pressured Alberta Health Services, or AHS, to accept inflated prices. And these allegations, coupled with the discrepancy in procedure costs, raise serious concerns about potential corruption and price gouging. And as many of you will know, we have multiple investigations underway in Alberta related to the issue of private surgical contracts, as well as other medical contracts for other medical supplies. The Auditor General of Alberta, the RCMP, and the government itself initiated its own review. On February 21st, the Globe and Mail published surgical procedure costs in Alberta, showing that most for-profit surgical procedures have significantly higher costs for the same procedures than public hospitals. In the case of Alberta Surgical Group, one of the for-profit surgical providers contracted under the Alberta Surgical Initiative, we see that hip, knee, and shoulder surgeries cost more than twice as much. And the higher cost to perform procedures in for-profit facilities compared to public hospitals is consistent with findings in other provinces, including BC, Ontario, and Quebec. So the first major finding of this research is that since the Alberta Surgical Initiative began in 2019, there's been a 179% increase in total public payments to for-profit facilities, also called chartered surgical facilities. In fiscal year 23-24, the amount paid to these for-profit facilities was $55.8 million. And this is only the facility fee. This does not include the physician billings to the Alberta Healthcare Insurance Plan. Facility fees are negotiated between Alberta Health, Alberta Health Services, and each private provider as per unit prices that AHS will pay the provider. Again, this builds in all of the overhead costs, including non-physician staffing, the costs of financing that private infrastructure, such as a mortgage, as well as the profit margin, of course. And between fiscal years 22-23 and 23-24, the average cost of an outsourced procedure increased by 52%. In other words, the rate of increase between 22-23 and fiscal 23-24 was 4 times higher compared to the increase between fiscal 21-22 and 22-23, which only saw a 13% increase. And so these findings seem to corroborate concerns and potential contract irregularities identified by the former Alberta Health Services CEO in her statement of claim and contract prices published by the Globe and Mail. We also see that public spending on for-profit facilities has outpaced public hospital spending by quite a lot. Since the Alberta Surgical Initiative, or the ASI, was launched in December 2019, public spending has favored for-profit facilities. Public payments to for-profit facilities grew 5 times faster than public operating room funding under the ASI. More specifically, payments to for-profit facilities increased by 66%, while public operating room spending increased by only 12%. And this is occurring within a broader fiscal context. Alberta saw an 11% decline in real per capita hospital spending between 2013 and 2022. These are the most recent years available from the Canadian Institute for Health Information. And this decline of 11% in real per capita hospital spending was the greatest decline in the country and really makes Alberta an outlier here. Real per capita hospital spending increased in the largest provinces. Quebec was 19%, BC 6%, and even Ontario 4%. So if Alberta hospitals seem like they are trying to do more with less, it is certainly not your imagination. Hospital expenditures as a share of the economy, measured as GDP, is another useful measure. This tells us whether public investments are growing, declining, in relation to the province's capacity to make investments in public goods like healthcare. Provincial hospital expenditures as a share of GDP in Alberta declined from 2.2% in 2013 to 2% in 2022, again, the most recent year available, making it the lowest in the country. And the province's declining investment in public hospitals comes as frontline physicians and healthcare workers have expressed quite dire warnings about hospital overcrowding and wait times amid the provincial government's restructuring of AHS. And in October 2024, just to provide a more explicit example, the Alberta Medical Association raised alarm as family medicine wards in the Edmonton zone were operating at 155% capacity and general internal medicine wards at 135% capacity. And what we also see is that for-profit surgical activity has increased at the expense of public hospitals. Between 2019-20 and fiscal year 23-24, the number of scheduled procedures performed in for-profit facilities increased by 55%, while hospital surgical activity declined by 1%. And put another way, the Alberta Surgical Initiative has cost Albertans $154 million in facility fees paid to these investor-owned facilities to build private infrastructure when existing public operating rooms are sitting idle. And yet, the initiative itself has only added about 16,500 additional procedures to the province's overall volumes. The most troubling finding, I think, is that public operating room activity was actually lower in the most recent year than even pre-pandemic. Consistent with the findings from my 2023 evaluation, also published by Parkland, provincial policy and funding decisions are encouraging the movement of limited staff, including operating room nurses and anesthetists already in short supply, into the for-profit sector, which, keep in mind, only performs the lowest complexity surgeries, does not provide emergency care, and does not provide follow-up care. And this is having real consequences on how Albertans are able to access life-saving healthcare in the province, and specifically surgical care. Median wait times under the ASI are longer for most priority procedures than before its inception. For 9 of 11 priority procedures tracked by the Canadian Institute for Health Information, median wait times increased under the ASI, exactly the opposite of what the government has claimed the initiative would do. And the increases in median wait times include knee replacements and all cancer surgery. So you can see in this graph from beginning from colorectal cancer surgery to radiation therapy to bypass surgery or CABG, all the way down to the longest increase in median waits to lung cancer surgeries. Again, breast cancer surgery saw the second greatest increase in median waits. This has all happened under the Alberta Surgical Initiative. So again, the exact opposite of what the government has claimed and continues to claim that this initiative is doing, which is to reduce surgical wait times for scheduled procedures. And I want to share a quote from Dr. Braden Manns, who was a former interim AHS VP until he resigned in 2023. And this was in a recent March 20th column published in the Journal. And he writes that AHS committee members suggested not proceeding for good reasons. The price, and AHS had lots of spare operating room capacity in those hospitals. The critical shortage was anesthetists and surgical staff. Private surgical centers where clinicians don't work after hours would impact AHS's ability to staff their operating rooms and manage after-hours emergencies. If your appendix ruptures or grandma breaks her hip, you expect a surgeon and anesthetist at the ready. And this is exactly what this report is identifying. We are shifting, or government, I should say, is shifting by policy and funding decisions, shifting that critical workforce from our public hospitals, our public system, to a for-profit sector. And keep in mind, there's a finite pool of qualified surgeons, nurses, allied health professionals, and support staff. And right now, we know that there are underutilized operating rooms across the province. And we also know that the vast majority of public operating rooms don't perform surgeries or have surgeries performed during evenings and weekends. So this is infrastructure that we've already paid for as a province. Sitting idle could be used, but it needs to be funded and staffed. And as I alluded to in my opening comments, this is not just a story playing out in Alberta, but this is part of a wider pan-Canadian trend where we see that the provinces with the greatest share of for-profit surgical activity generally have had the longest median wait times. So when you look at the provinces, again, the date here is these are 2021 data. It's the most recent data that we have to be able to compare. But it provides quite a clear indication of the provinces that have been most eagerly pursuing for-profit outsourcing have not been the top performers in the country. So we look at Ontario and BC, where they respectively outsource 3 and 5% of scheduled surgeries. These are provinces that have had actually much better, much shorter wait times for these three priority procedures, knees, hips, and cataracts. When you look at Quebec, Alberta, Saskatchewan, outsourcing a much larger share of scheduled procedures in those provinces, wait times have generally been much longer. So, this is a concern moving forward. And despite improved performance from Alberta in 2023, the most recent year available where we have comparative data, for hip and knee replacements, there has been an improved performance for Alberta. But BC and Ontario continue to outperform the province and, in fact, for most priority procedures in 2023. So looking forward, these findings come at the same time as the former AHS CEO has made quite serious allegations of political interference and potential corruption involving political staff, potentially cabinet ministers, and a for-profit surgical facility. The Auditor General's investigation into these serious allegations is urgent and should be met with the full cooperation from the Alberta government. However, while the addition of the RCMP criminal investigation and a third-party review signals the gravity of the issue, these probes may still fall short of ensuring full transparency and accountability. What we need to see in the province is a public inquiry with the ability to summon witnesses to testify under oath. And this remains the best mechanism to uncover what's happening within Alberta government contracts with these for-profit facilities, and to fully understand the extent of the allegations that have been made by the former AHS CEO. And to wrap up, the Alberta Surgical Initiative, with 5 years of data now to analyze, it has not improved total surgical capacity, nor wait times for most priority procedures. The provincial government's persistent claims about the benefits of this initiative are not supported by government's own data. And again, this report is important because it's drawing on publicly available data that the government has at its hands as well. This report draws attention to serious questions about transparency, prudent public spending, and government integrity. And we also need to take the Canadian and international policy experience seriously, especially from the United States. We know from lessons in for-profit healthcare delivery across the United States and across the world, in fact, that there are greater risks to patient care, greater risks to value for money, and also much greater risk of fraudulent billing practices when profit is the overarching objective of these corporations and these facilities. And we also need to attend to the fact that when for-profit interests and corporate lobby groups become entrenched, these issues are only going to fester. And I would say, it's really long past due for Alberta and the Alberta government to take these lessons seriously. So I thank you for being with us. This is a really important discussion and topic in Alberta, and look forward to your questions and discussion.
Great. Thank you so much, Andrew. Very much appreciate the very concise. You were actually quite speedy as well, which is great. Um, a couple of quick things. I realized I was remiss in my enthusiasm to get to Andrew. I completely forgot to introduce myself. Um, I'm Jason Foster. I'm the director of Parkland Institute, and just mostly just your host today, which is why I kind of think I skipped by that. We are recording this session, and the recording will be made available publicly on Parkland's YouTube channel within the next day or two. So we have lots of time for some question and answers. The way that this is going to work, don't use the chat function because other participants in the webinar can't see the chats. The only people who can see the chats are the panelists. So what we're going to use is, if you'll notice down in the bottom end of your screen, there's a little Q&A with a little question in a speech bubble. You want to put your question, you'll type your questions in there, and then I will kind of sort of sort through and try and sort of see if I can, I'll then read them out loud for everyone participating and for Andrew. I may at times, mix and match or kind of combine a couple that seem to be kind of hitting a similar topic. I might combine them together, and I'll try and sort of pick things that I think might, help us create a bit of a flow for the conversation. Um, so maybe I think I'm going to start with a very specific one, Andrew, because it was one of the first ones that came out, and it's probably you can kind of address it. It gives me some time to read some of the others. Um, it says this person's looking for clarity about the graph showing real per capita public hospital spending. Is the point of that to show how funding has declined in some provinces? They say that they're not seeing where funding for private facilities has grown. There's only information on the table about public hospital spending in the graph. So maybe you can maybe answer that and maybe talk a little
Yeah.
bit more about that.
Yeah, so in the report itself, and I'll speak to where folks can find the data. In the report itself, Table 1 includes a breakdown by year, each year of the Alberta Surgical Initiative of public payments to for-profit chartered surgical facilities. In 2019-20, it was about $20 million annually. And by 23-24, it increased to about $56 million for that year. And so that increase is coming at the same time that there's this broader trend that we're observing in Alberta where total provincial per capita, real per capita hospital spending, so this is adjusted for inflation and for population growth, we're seeing that declining. And so this is I really wanted to contextualize what's happening with the relative investment and payments to for-profit facilities at a time when Alberta hospitals are really under fiscal austerity from the provincial government. And there's an explicit policy decision being made to say, on the one hand, we're going to keep boosting to the tune of 179% payments to for-profit surgical facilities under the Alberta Surgical Initiative, but we're seeing real per capita hospital spending decline over a 10-year time frame. And then when we look more specifically at public operating room funding, we're seeing that public operating room funding is not growing as quickly, so public operating room funding is a piece of total hospital spending. And so when we look more specifically at that, it is not increasing at the rate that we're seeing the increase happening on the private for-profit side. So the point here is that government is making a decision to say, we're going to significantly increase and boost public dollars flowing to for-profit facilities at the expense of our public hospitals. So I hope that answers your question.
Great. Thanks, Andrew. I've got a couple more that I'm going to stick for the moment to some questions that are specifically about details in the report, and then there are some questions in here that I think will kind of broaden our conversation out a bit. So I'll get to those in a minute, but let me give you a couple that kind of deal with the specifics. One person is wondering how much the population spike in 22-23 contributed to increased wait times, or is that already factored into your data? And then maybe one other one that's kind of quite specific. Did you find any clear correlation between the increase in spending on CSFs and the ministerial directives issued directing contract rates for CSFs? So those are two kind of different questions, but both kind of focusing specifically on your
Yeah,
data.
so the challenge with this type of research is we don't actually have the unredacted contracts for individual facilities available to scrutinize. What we have to work with is the total payments to for-profit facilities that are on the public record. They're part of the public accounts. And it would be very useful to be able to understand, which is why the Globe and Mail reporting has been extremely insightful because they have released internal costing about the relative costs of certain orthopedic procedures relative to the cost of performing them in-house in public ORs. So the short answer to your question is, we are at the point in time where we as citizens, as taxpayers, as patients, I think have a right to understand what is actually happening within this sector when there's such significant public funding flowing to these facilities. What are the rates that are being negotiated? What are those contracts? I think it is incumbent upon government, and I think this is what a public inquiry would help us with, is really providing transparency around what those contracts actually contain in them. And so there's a limit to what we can do as researchers just using these aggregate numbers to understand what's happening, looking at volumes and total payments. And so we don't know other than what's been reported in the Globe and Mail based on internal work costing by AHS. We don't know what those individual facility fees are by facility. So I hope that answers the second question, and then Jason, I'm already forgetting the first question you asked me.
That means I have to go back as two. It was about population growth and whether you had whether that how that contributed to wait times and whether your presentation of the data had factored that in.
Yeah, so using the Canadian Institute for Health Information, wait times is probably the best way to account for population growth. So understanding how long the waits are give us a good idea of they account for population growth because the number of patients going on the wait list, waiting for procedures and having procedures performed, is an indicator of the demand for those procedures, and that obviously accounts for population growth. There are certain limitations to what the CIHI or Canadian Institute for Health Information data tell us. It's very helpful because we can make interprovincial comparisons, and it's collected nationally by an independent, nonpartisan, nonprofit agency. But it's also only telling us the wait from the decision by a specialist or surgeon to treat or perform a surgery to the completion of that surgery. So when the surgery or procedure is completed. So it doesn't tell us the wait time from a referral from your primary care provider to see that specialist or surgeon. So there's that wait time that's not accounted for in that data. And that's often where some of the most significant bottlenecks are, because we still predominantly have a system in Alberta, much like the rest of the country, where physicians and specialists and surgeons work as independent business people and they maintain their own separate wait lists rather than moving to what high-performing health systems do internationally, which is centralizing that wait list for procedures or for consultations among that specialty group or that procedure. So if you needed to have a consult with an orthopedic surgeon for a knee replacement, having that referral centralized to that group of surgeons within that same area, also working with advanced practice physiotherapists and dietitians and others. These are quite effective models to reduce wait times and reduce the variation in waits. And that's something we can talk more about, but I know there's lots of questions.
Great, thanks. I've got two that I think are basically hitting the same topic that I think might be not a bad time to bring into the conversation. One is do any of these initiatives to private surgery facilities breach elements of the Canada Health Act? And then a related question is there any impact to federal health transfer payments either now or potential ramifications in the future because of this initiative?
So we know, and it's a great question, something I didn't touch on. We know that a number of for-profit surgical facilities across the country are also will take private pay patients. And some of this is being done in potentially a gray area, but if it is not against the Canada Health Act, it's certainly not in the spirit of the Canada Health Act, which is um, charging patients privately for surgeries when you're an out-of-province patient, saying that's not part of the Canada Health Act and therefore it's okay. It's certainly not in the spirit of the Canada Health Act, and we also have a provision in the Canada Health Act called portability, which means that you are not to pay out of pocket depending on where you live in the country. So to put it simply, there are some very significant concerns about lack of compliance and unlawful extra billing, as it's called, which is charging patients out of pocket for procedures and care that is publicly funded and publicly insured by a provincial health insurance plan. And this has been, I've done a lot of work on this topic. We've seen it across the country and even among clinics, for-profit surgery clinics that have been contracted to perform publicly funded procedures, still engaging in that behavior. There's also issues of upselling and coercion that takes place in these environments where patients feel like they're not going to get their surgery, or to say, no, I don't want to pay that extra fee for a better lens or something that the surgeon encourages you to pay for out of pocket because it's an upgrade. They feel compelled and coerced to pay that because it means confronting the person who's going to perform a procedure on you. So there's a very significant power imbalance at play. So the short answer is yes, the Canada Health Act is in play here, and I have a lot of concerns about the more that we entrench a for-profit surgical sector where we have on the record, and I've been engaged in this research for about a decade now, they have engaged in unlawful extra billing, and that is not compliant with provincial statute or the Canada Health Act.
Great, thanks. I have a question here that's asking um, about something you don't mention in the study, which is the reference to infection rates, complications, or the quality of outcomes. And so this person's wondering, do you have any information about this over the 5-year surgical initiative?
Yeah, great question. And I would also suggest folks for a much thorough discussion and review of the academic research literature on quality and outcomes when you have for-profit surgical delivery and outsourcing. I review this literature in the 2023 Parkland report, Failing to Deliver. So I encourage folks to check that out because there is a section on quality of care and outcomes. And there's been a growing body of evidence around the risks and the observed increased rates of preventable mortality associated with healthcare outsourcing. And much of this research comes out of the United States and England, where there's been a much longer history of for-profit surgical delivery, but it is most certainly a concern. I don't touch on it in this report because one of the challenges is we don't have good access to outcomes data. So there's also we don't really know what we're getting. We don't even know what we're paying for in some senses. There are issues in England where they've seen a significant burden on public hospitals as patients with complications end up in public hospitals after having a procedure performed in a for-profit facility. So yeah, the short answer is yes, there are lots of quality of care concerns, risks of increased rates of mortality, preventable mortality, and this is a very significant issue. Certainly, it's been discussed in the academic literature, and it's something that needs to be part of our discussion too going forward.
Just a reminder for everyone that we have dropped the links to both this new report and Andrew's last report in the chat, so you can kind of find the links there for some of because some of you are looking for the report, so that's how you'll find it. I have one here that's again trying to look at sort of that downstream impact that maybe doesn't cover your report directly. This person talks about how patients being seen at these private clinics are very low risk surgical candidates. Many of them, they argue this is why wait lists worsen, that many of these people aren't even in the top 50% of their respective lists. But then despite that, they're asking surgery is never benign, their complications can happen, and these complications end up in publicly funded emergency departments and hospitals. So the question is, does the government revise their payments to these facilities for these complications? And if they don't, can they, or in your opinion, should they?
The short answer is I'm not aware of any clawbacks of payments. That's not how these payments these contracts are negotiated with these facilities. There is no clawback if patients need to seek care in public hospitals. And we know this to be happening. I've had numerous conversations with emergency physicians saying that they will see, the chartered surgical facility closes, their day is done at 5 o'clock, and there were patients that needed continuing inpatient care and needed beds, and so they were admitted through the emergency department, and they needed inpatient beds in the hospital, and they had to make room for numerous patients coming from that for-profit facility. So there's all kinds of costs that we're not accounting for, and this is borne out by the academic literature in the US and England, specifically in terms of basically kind of downloading those costs onto the public hospital system. And obviously, this is having an impact not just on the costs for public hospitals, but also their capacity and their ability to treat patients and move patients through the hospital system. So significant knock-on effects. And then I'm already forgetting the other part of your question there, Jason.
I think it was whether, in your opinion, should the government be factoring into their
Oh, yeah.
contracts with these facilities that if they have, complication rates that, if they claw that back, right?
Yeah, at a minimum, we need to be transparently tracking that. I mean, there's been a lot of effort and work done in what we call high-performing health systems to move towards a more open and transparent culture of patient safety and publicly reporting complications and lapses in quality of care. And the intent is not necessarily punitive or to name and shame, but it's to work towards a quality of improvement and safety for patients. And so I would say at a bare minimum, we need to track and we need to publicly report what's happening in these facilities and understand that. I'm not confident at this point in time that we even have those data points, should we want as researchers to study them. And that's a significant concern when we're talking about hundreds of millions of dollars flowing to facilities to perform procedures where we don't even necessarily know the outcomes that we're getting. And so it's not to say, the same attention needs to be applied to our public hospital system as well. No, there's no question there. But right now, we're basically moving in this direction with very little information about the kind of quality that we're getting, but lots of concerns around the implications for our public hospital system and for patients just based on what we're seeing around wait times.
So I've got a question here that's about looking back at sort of the broader problems within the public system. So they're saying if there's a recognized need for more surgical services, what are the boundaries for increasing capacity in the public system? Are there aspects of ramping up services that private providers have figured out that the public is struggling with? And so then to sum that up, what needs to happen to create more capacity in the public system?
Yeah, so I think it's twofold. There is existing physical capacity in our public hospital system. There's no question there. Many operating rooms are not fully utilized just during normal operating hours, sort of daytime hours. That's the case. And then beyond that, you can also create additional capacity by extending into evenings and weekends. And this has been done in a much more significant way in British Columbia, for example, in working down the pandemic backlog. And there was significant effort to open shuttered operating rooms that weren't funded and weren't staffed, to make sure that at a minimum you're using all of your daytime capacity from there. You look at your evenings and weekends. The challenge there is making sure you have the workforce in place, but the starting place needs to be properly funding them so they can staff up. And I think one of the biggest concerns is you don't just turn the tap on and off in terms of staffing up healthcare services. And what's happening now in Alberta is there has been a very clear policy and funding direction to increase funding and staff up the for-profit surgical facilities at the expense of public operating rooms. And so, you to move that and switch that is going to be a challenge now that kind of genie is out of the bottle. But it needs to happen because look at our cancer wait times. I mean, cancer surgery wait times. These are really the canary in the coal mine for what's happening around the movement of health human resources within the health system over to the for-profit side. So just back to the question, we need to do that capacity planning exercise. The government actually contracted a consultant to look at unused OR capacity in our public hospitals in Alberta and found that there was a considerable amount of unused capacity. But I haven't heard a commitment to date about making sure that we're taking advantage of that physical infrastructure that is sitting underutilized and idle. And that needs to be the starting place. We've already paid. I think the important part is citizens have already paid for Alberta's hospitals. That infrastructure has already been financed and paid for. What we're now paying for is investors to open up new physical infrastructure and pay for their high cost of financing and a profit margin to operate those facilities. And that's why we see such high per unit costs to pay them a premium to open up a brand new facility and on top of that be able to make a profit. So it doesn't make any sense from an economic perspective when we already have the physical infrastructure in place, but we're not using it. That's a huge loss to taxpayers in the province.
Okay, I've got a pair of questions that I think are the same question, but allow you to come at it in whichever way I think you most want to. The first is, what is the most charitable narrative possible that we could make about why the government is taking this health policy approach? But then kind of coming at it from the opposite direction, based on the information you've studied and presented, do you think this is a deliberate effort to privatize healthcare? So you could take that whichever direction you want.
I mean, I'll be very frank. We have 5 years of data. The government, even if it doesn't want to confront the data, it knows that things are not improving. Look at the wait times. So to continue and double down on this policy direction when you are literally denying patients more timely access to care, to surgical care, is completely befuddling. Why would you do this? So, I can't speculate what's going on in the minds of the premier and cabinet ministers, but what I can say is if you are basing your policy decisions and funding decisions from the evidence and what it tells you, you would look at this and say, wow, this is really not working as we intended. If the intent was to reduce wait times and increase total surgical capacity in the province. But I mean, I think it's a very reasonable question to ask, was that ever the intent? And I think at this point in time, when we look at what's happened in labs in the province, when we look at other privatization initiatives, I think we can see that what is taking shape in Alberta is building a for-profit hospital sector. That the intent is to dismantle Alberta Health Services and have hospitals compete with for-profit providers. But then at the end of the day, government still holds all the cards in terms of determining who gets what. And we've seen in a very top-down manner, all of the contracts seems to be, the direction seems to be coming centrally from the Alberta government itself. So how can you actually compete within a system where the public hospitals are being asked to do all of the complex work, all of the surgical care that takes more time, is more resource intensive, also deal with any complications that arise from the cream skimming that's happening in the private for-profit facilities, the least complex, most profitable procedures. Any of the more difficult complications that arise end up in public hospitals. So, the system, public hospitals cannot function in that type of system. They are being set up to fail. And I think that's what we are seeing is you are setting them up to fail on a whole host of life-saving procedures like cancer surgeries. They can't operate in this environment where anesthetists are fully subscribed in the for-profit surgical centers and not available necessarily to provide emergency services because that was never thought of at the outset. So there's a number of ways where the guardrails have not been put in place at a very minimum to protect our public hospitals to deliver the life-saving care that they deliver and that Albertans depend on.
I'm seeing lots of questions about the public inquiry, and I will get to them. I thought that just might be not a bad way to kind of close off the webinar. I'm gonna jump back to a specific question for a second. Um, Someone's just sort of asking that they're sort of looking at the report and they're seeing that payments for your reference, Andrew, page 6, payments to these private facilities went up 95% in 23-24, while the procedures performed went up only 28%. And they're kind of wondering what your understanding of the explanation for that discrepancy might be.
Yeah, that's a good question. And I think this is, again, one of the challenges. We don't know the case mix of all of the procedures being performed in for-profit facilities. What we do know is that it's outlined in legislation and based on an approved list of procedures that can be performed outside of hospital settings. That's been consistent since the outset or the inception of the Alberta Surgical Initiative. So we know generally that they are the least complex. They are the most routine procedures. But we don't necessarily know the relative mix year by year. And so that's a significant limitation of this research, without a doubt. It would be very helpful if that information were publicly available and reported as part of the government's dashboard. Because I think when we look at what's happening in cancer surgeries, we are seeing the fact that when you're prioritizing the lowest complexity procedures like cataracts, which, don't get me wrong, have a significant uh, impact on people's ability to live their daily life and on their quality of life and their ability to see, most importantly. But when we look at that, the focus there in relation to cancer surgeries, for example, we are seeing the focus on a lot of these surgeries that don't necessarily have the kind of the life or limb impact in the same way. So I think the question is, I don't know, and that's part of the reason why we need a public inquiry is we need to have this information on the public record. What is going on? And I think the allegations made by the former AHS CEO raise a lot of very troubling issues about what's going on. And the benefit of a public inquiry where you have the ability to summon witnesses under oath is what's needed at this point in time. There are these discrepancies, and we're trying to make sense of them as best we can, but without all of the data in front of us.
This next question isn't directly connected to your report, but you might have some insights on it. And because I think it is part of the broader theme that we're talking about today around healthcare privatization. It's a question about the government plans to transfer ownership of AHS facilities to Alberta infrastructure. So it's not privatizing per se, but they're wondering if you have any concerns about that particular strategy as they restructure the system.
Yeah, I have a lot of concerns about that direction because what it looks like is well, and not just what it looks like. Government has made this clear in the budget documents. Uh, the Alberta government is planning to have Alberta Health Services lease its own hospital facilities from government at lease rates that they will determine, essentially. Like we don't know what that arrangement will be, but what I will say is this looks like a very clear um, tactic or strategy that's used in private equity, where they acquire they acquire healthcare facilities. It's most often in the private long-term care sector where private equity, uh, they acquire long-term care facilities and they separate the operations from the real estate. And they do what's called a sale and leaseback. And they basically hollow out the equity from the real estate and lease the real estate to the operating or operations arm, a separate company. Sometimes it's a related company, but at really exorbitant lease costs that end up bankrupting the operating provider. And so in England, for example, this arrangement um, led to one of the largest failures of a chain, a long-term care, for-profit long-term care chain in the country. And this is often a strategy in the US. And we're seeing a lot of these issues come to roost in Canada as well as we see more private equity enter the healthcare sector. And so, my concern is what appears to be happening or taking shape is that the Alberta government will could very possibly charge inflated leases to nonprofit hospitals, AHS, um, in order to maybe demonstrate that they're not solvent. They can't maintain their finances. And I think what we're seeing in this province is a very explicit strategy of undermining Alberta Health Services. And this seems like the next step in that, which is to say, you don't control your assets anymore, your infrastructure. We're going to lease it back to you at, at an inflated rate. We don't know. The government will control that, and it's only going to pose more challenges down the road for Alberta Health Services and our public hospitals when they have very little control over that arrangement. So I'm very concerned about it. And I think it's not at this point in time, it's not far off to say, are they looking for other investors to own that hospital real estate? I don't think this is out of the question. Would they be looking to US hospital chains, US private equity? I don't think anything is off the table right now. Entangle Alberta more with the United States. I think these are all reasonable questions at this point in time.
Great, thanks for that. Again, I think another question that kind of addresses trying to kind of get you to tease out a little bit more in the report is they're wondering if there's a difference in your economic analysis around cataract surgery versus joint and bone surgery, right? Because cataracts are very high volume, right? They're kind of done kind of standalone, they kind of chunk them through them. Well, obviously, joint and bone surgery are more complex. So, do you think that there is a difference in terms of understanding this in the context of the private surgery initiative?
It's a great question. And again, I would say we we need to know more about again, the activity, the case mix, what's happening in facilities. Um, and that is I would say that's one of the challenges is we need to know more about what are the relative costs of each of these different types of procedures. And that I think that's something that should be on the public record. To answer your question, no, it's not directly discussed or analyzed in the report, but it's something where cataract surgeries are very quick with advances in technology. The billing rates in a lot of provinces on the physician side don't reflect those advances in technology and the fact that it's a very quick procedure now. So it is very common to see ophthalmologists among some of the highest billing specialists in every province because of this. I think we need to ensure that public dollars that we're paying for healthcare reflect a lot of these changes and advances in how long it takes to perform some of these procedures, and the fact that yes, there are differences in kind of the relative complexity of different procedures, but no, the short answer is no. I don't look at this in the report.
Okay, so as we're getting close to wrapping up, I should address there's a whole bunch of questions that are one focusing around this public inquiry idea. And, there seems to be some support for wanting that to happen. But a lot of the questions are revolving around how do we make that happen? Like, how do we get the government to actually launch a public inquiry? Is there another way to get to another public inquiry that doesn't require Danielle Smith? So there's a series of questions, but all of them, I think the core of them is how do we make a public inquiry happen?
That's a great question. Yeah, I think, at the end of the day, it's going to take um, Albertans to say we demand this. Like this is necessary to happen. I think we need to continue raising these issues and talking about these issues. I leave some of these questions to lawyers and legal scholars to grapple with some of the more immediate practical considerations. But I mean, I do think government has to realize that if we want to maintain, um, the integrity of our publicly funded healthcare system, people need to have comfort in knowing how their tax dollars are being spent. And I think we are at a critical juncture here in a lot of concern and questions about the integrity of how public dollars are being spent. And so it is incumbent, I think, upon government to recognize the gravity of the situation and they need to hear from constituents. They need to hear from the public. Uh, we need to call for things that are in the public interest. And I think others probably have other ideas about how to, kind of ask for that or push for that and make it happen. But I think we need to all do our part to raise these issues and have these conversations about the importance of how our public dollars are being spent. I think we're at a moment in time where we're seeing actions from people like Elon Musk, where they think the public purse is to be their personal to be a personal benefit to them. And I have a lot of concerns with kind of the narrative and the way that things are unfolding in Alberta. This idea that public dollars, we don't have a right as citizens to ask questions about how our dollars are being spent and if they're actually delivering solutions and better healthcare for Albertans. So I think, this is a real moment in time where we need to demand that our public dollars are working for us and not for a select few.
Great. Thanks, Andrew. And thank you so much for this presentation and for spending this time with us. And thank you to all of you for the time you've spent. And if you like this kind of event, if you like this kind of webinar, you like the kind of the work that Andrew and other researchers are doing, please know the Parkland Institute survives by donations from folks like you. We don't get government funding. The University of Alberta doesn't give us any money. So if you want to support more of this kind of work, consider going to the Parkland Institute website and donating or making a pledge to donate. It will go straight into the hands of people doing good work like this. And so thank you. It's 1 o'clock. And so thank you all for coming and attending and taking an hour out of your day to hear about this important issue. Once again, a final thank you to Andrew for both the report and your presentation today. And I hope that you all have a good rest of your day. Thank you very much.
Thanks.